reverse back to the picture, because things you will really have to know is what takes up most of the counts when you're looking at them. So the neutrophils take up a good amount of your white blood count. Keep that in your mind. And the next most dominant cell is going to be the lymphocyte. So these two are always present. Always. When the others start becoming more present, then the ratio starts shifting. That kind of starts telling you what's wrong for an infection. So they all react to infection. They all react to a stimulant. These guys kind of like to react to parasites and inflammation, which is an immune response. Because this one likes to kick out histamine, and this one responds any type of allergen coming in or a parasite will stimulate the eels. So in theory, when you do a normal white blood smear, you really don't see them. Look at this 0.5 to 1. They're really not there. EOs too, they're like 2. So for every 100, there'd be 2. So the likelihood of it's not there. So this is, pretty nice the way it breaks it down. Neutrophil, however, takes up most of it, 50 to 70%. So there will always be 60% neutrophils. And then you have the lymphs. They usually like 25, so like 25% are the lymphs. They're always around. That's their job. And the monocyte, 3 to 8, the only time this goes to the roof is conditions like mono and stuff will raise them. But in theory, it's this cell being affected. There's an early phase of mono. If you run a mono spot, it's negative. Next thing, look for 30% atypical lymphs. If you're seeing that, you got mono. So we're going to go into that. We'll go into mono. The more important thing to me is understand where they come from, the cells, their prime functions, and then I'm not going to go into how they all develop, all stages of their development. That's ridiculous. I'm going to PowerPoint. That's the FYI. You get that in the PowerPoint. A lot of that we're going to just blow over. Okay. The key thing is, why is the count elevated, or why is it depressed? What you should look for as a healthcare person. You're not becoming a total hematologist, so you're not going to deal with that. The only person that does, a hematologist specialist. That's it. And they do exist, and that's what you refer to when you got something that's really rare. Okay? So you will cross this, not that often in life, but you do cross. I've had a couple of cases that crossed that way, and they had to be a hematologist, and with a diagnosis like what it was, and I hope it was out the money for the diagnosis. The hematologist actually said to the patient, it was a chiropractor who found this thing? Yeah. And you went to all these other specialists? Yeah, but he's the one who found it in my blood work, picked up on what's going on. I said, wow, that guy should be commended for what he did, because most medical doctors don't need to find this. So it's not the degree, it's not the title, it's the person. So what is it? So you put your heart into what you're doing, and usually you don't screw up. That's what I'm trying to explain to you. That's what I'm trying to teach you here. Okay? Is just do the best you can at what you're doing. Learn the material because first of all, it's interesting to you. And second, you want to be the best of what you can be. Because you're going to see things. Nurses read lab work all the time. So remember that. You're involved with this. And you can pick up a mistake that's being missed. So just pay attention to it, okay? So that's why we're breaking this up for you. This is so important. So your normal columns, we said, were like, they put it for, so make it easy, 5 to 10,000. Round it up, 5 to 10, easy. The red blood, they really didn't tell you, they just tell you liters. But usually red blood is 4 to 6 million. 4 million to 6 million is your normal red blood. So it's usually in that range. White blood in that range. So if there's a shift up, usually it's an infection taking place with the white. So we'll talk about a little more. This is showing you what they look like. So we look at the So in other words, they're granular looking. You know? So neutrophils, so the fills are granular. We said that. The sites are smooth. They don't have granules. The monocyte, the lymphocyte. Okay? So the neutrophil needs, and these guys really love to fight bacteria. That's their prime thing. We're going to go into that. So all this other stuff, here's the other thing that's important. They are all phagocytic. That means they love to eat another cell. Bacteria, they eat it. And inside them, they have enzymes to break it down. Peroxides, or they'll lyse it with lysis. Bleach lives in these cells and destroys the bacteria. That's how they kill it. They just eat it alive and digest it, plain English. And we'll go in to see what's in there, okay? So you don't need to know all this. They don't live long, no, because they're always out there fighting. That's their job. But one thing to remember, they're all this ability. They all can phagocytize things. So neutrophil, we said the most numerous, 50 to 70% of your white blood count is neutrophils. It's the, you know, like the bully of the white blood cell. He's the boss. And they're big. They have to be. They're going to eat things. You know, little tiny cells not going to go like and eat something that's this big. These have to be big so they can handle a virus or a bacteria. And we don't care about the dyes and what they look like, so don't worry about this. So they're twice the size, 50 to 70%, but they're very phagocytic, referred to as the bacteria slaves. Bacteria slaves. So usually these guys are always involved when you have a big strep throat, you got bronchitis due to bacterial infection, a UTI due to bacterial infection. They're going to elevate. They'll be elevated. So your count can elevate up to like 12, 13,000. And you're going to see more of these. So at 70%, there might be 80%. And also you'll have, I'm going to say, EMN, which are premature ones. So you'll see a lot of premature type neutrophils, polymorphic neutrophils. So they're premature, so a lot of fighting with band cells. So you know that. So you got a high infection with a lot of bands. I'm not controlling the infection. That means the infection is still out of control. And there you go, it's still out of control. So that white count will elevate, and these will elevate with it. So now you know you're dealing with a bacterial infection. That's what they look for when they do blood work. Run blood work and there's no shift, no change, well, not bacteria. That's one thing they know. Okay? So there you go. So they synthesize, oxidize, they bleach a hydrogen peroxide. They're nasty. They're nasty. You know, and it's so cool to watch these things chase them. They're like a stealth missile. They will not stop until they get what they're chasing. So there are, if you go on YouTube, so you'll see people filming them, and these things are chasing bacteria like there's no tomorrow. The bacteria is going all over the place. This thing's and finally just boom, gets it, and it's gone. So they don't. So why would we have to give you antibiotic then and take 2 weeks? Because the bacteria is just multiplying too fast now. So what the antibiotics are going to do is give them a chance to catch up and do their job. And that's what antibiotics do. And when they do their job, they kill the bacteria. They don't want it. They rid it. So that's their function. So the antibiotic can stop replication of the bacteria, weaken the bacteria's wall so these things can destroy it faster and easier, screw up its DNA, RNA when nothing's going on with the thing, weakens it. So there's 4 different ways bacteria antibiotics work, and we'll learn about that when we take Professor Vito and micro. That's what micro is. So you'll be talking about these again in micro because they play a role. Then we go to EOs, 2 to 4%. You hear the commercial, eosinophilic asthma. So this new drug targets these eosins from stop coming out. If I can stop them coming out, I stop the asthma from happening. The reaction doesn't take place. So that's the way they treat it. stop the reaction of the white blood cell to react to it. So I don't react to the stimulus, I don't get an asthma attack. That's ways of treating asthma. But the eels love to rise with that, and also large parasitic worms in tapeworm, and these things are, usually you find out what the symptom before that would happen. Cramping, blood in the stool, the little tail falls out in the stool. I mean, they literally can grow, and then they stick out your rectum. So they're going to poison it. And so the other professor, Meglio, who teaches here part-time as a microbiology professor, he was the head microbiologist for the health department in the state of Rhode Island. And they had a case of a beef tapeworm, which isn't as deadly as the fish or the pork, but it's still there. And it was 16, 20 feet long, the tapeworm. And the person got it from eating at the one here, the longhorn, or rare steak. She picked it up. And they go to the meat, they found out tapeworm. Now, if you cook the meat all the way through, you would have killed it. So you're gonna go medium well or better. You're gonna get that center 160 so you can kill it. So when you eat your steak like it's still alive, you can get these things, okay? Fish especially. Fish has to be cooked. Almost all fish carry something.
You can't kill it by chewing it?
No. It's microscopic. The acids have no effect on your stomach.
You can't get it for $1,000.
Oh, sushi, yeah.
So you can get it from
Of course
sushi.
you
I
can.
freaking sushi all the time.
I've read a lot of studies on people who, this guy was so sick, losing weight and everything, they finally had a huge tapeworm in him from sushi.
That's perk of being vegetarian.
What's that?
So this is the perk of being vegetarian.
Oh yeah. I feel guilty. I like my steak from the wing.
It's, look, eating anything raw, there's
Beef and then
there's
it's half over half
a,
over.
is a risk, all right?
Do not miss it.
Like what?
Mm.
Yeah, you pick up hepatitis, all that stuff. Or you cook it and you cut the likelihood of that happening. So when it's cooked, whatever's in there, well, you pick up salmonella
I know, that's what I'm saying.
vegetables, so we'll make a
Stay out
difference.
and be vegetarian, you see.
Yeah, look, there's dead vegans in the cemetery too. So there you go. So the point is, usually the way the oyster, they found them and stuff, usually, look, I like raw seafood too, like clay, little necks and stuff. And it's like, oh, I mean, it's delicious. But the point is, when you eat the thing, you're saying to yourself, I'm running, but where did they collect it from? You know what I'm saying? It's not near a sewage plant where they live this big, because they live off waste. I think the bigger they get, the more waste they're living off. They dwell in the ground. It's just like swordfish and tuna and all that stuff. The same thing. They're bottom dwellers, a lot of them, and they, a lot of mercury. So it's common sense. So we don't want to eat raw things if we can avoid it, okay? And after you get done with veto, you're like, oh, I can't touch nothing. Flu. Best way to prevent it? Wash your hands first. Tell you to prevent it. You're not gonna pick it up from the air. You're gonna pick it up from the damn formula. You're gonna pick it up. Same thing, stomach bug. Wash your hands. Kids don't. That's why they all spread it to one another.
And then freaking hands in their mouth.
Right. Their eyes, they go to the bathroom, poop right there, Big 4-year-olds. They're little incubators to make us all freaking sick. That's why there's flu. Close down the schools for like the month, the flu will go away. It'll calm down because this week was school vacation, so all that stuff calms down. Everybody said, oh, so many kids have the stomach bug. I said, yeah. Are you eating from their dish? No. You're washing your hands? You go to the bathroom in there with them? And stuff? No, then you're not going to get it. There's precautions that you don't get it. Healthcare workers, you're gonna be near this shit all the time. I'm not even there sick people, you can tell they're sick when you go in there. It's like, what the frick you doing here? Don't deal with that. You know, so that's the biggest thing. So parasites and any type of reaction, especially asthma is a big, so any type of allergy reaction. Now the other guy, the basals, this is your histamine reaction. So you're allergic to something. The histamine, you really don't want pouring out in you because that's going to close everything up. You know what I'm saying? When you eat something you're allergic to, almost your airway closes up, almost a rash breaks out on your body. That's another histamine reaction. So that's not good. So mainly what you take is antihistamine, you block it. So this will be any type of inflammatory change in the body will attract this. So yes, these also would come out with this. It's not just one, they come through. Because as the blood supply changes, they're attracted. Histamine's going to create more blood to the area. So you get the redness and the warmth of an area when it's inflamed. That's a histamine reaction. So you want to stop that. So there you go. So these three, one big job, the big bully of bacteria, the other two deal with inflammation of the body. Fighting parasites, fighting off whatever you're allergic to. And they recognize a protein, they don't forget it. When you see that, when we get to these other guys. Not eating, we have the lymphocyte and the monocyte. The Adrian varieties. Lymphocyte is second numerous. So you should know that the lymph and the glucose, the neutrophil are the most common you're going to see in the snail. Now you should know right off your head. And you should get that in your head and know it. After you go through this lesson of this stuff with this course, you shouldn't forget this. You're going to be using it. Hopefully some of you in fall when you're in your programs. You're at that point now, people. You're in your last killer science. Micro's not a killer. You're going to be fine with micro. Micro's different, but not a killer because these two courses get you ready for it. And you're also finding now you're better prepared for this course than you were the last course. You have a foundation now. And that's what I'm finding is teaching the AP2 is a lot easier to get a point across than the AP1. Because you guys understand now. You know how to study it, you know how to rip it apart. You're going to be fine. You're probably going to do better in AP2 than you did in AP1. So in the end, the mixing of these courses was a better move because you get a better student by the time it's over. You get a better handle on the two subjects compared to the second. Because you don't get the same, I taught physiology, and they're not as prepped as you guys are coming into AP2. So you are better prepped. Never admit that to the nursing college. You are better prepped. You don't admit it. You know, even if you're wrong, tell your wife you're wrong. Or your spouse. You don't say your husband, well, I was 100% wrong. No. I was a little bit, but you started it. All right, so that's how you do it. You know, me and you stop arguing about what's it mean. You were right, so I let it go. All right. So we break these down into T and B. We're going to not talk too much about these now because we're going to do a whole lecture on them when we do the lymphatic system. That's your last system. And it's quick, because we don't go into all this detail again because we just go right to where they come from, what they do. So you're going to see the lymphocyte, the T lymphocyte, acts against viruses, infected cells, and tumor cells. So you can see how they're using these things. So these like to live in the tissue, these come mature right out of the marrow. They come up with the circulation. These mature in the tissue. They all form in the marrow, then it matures in the tissues. Which you see tonsil, thymus, that's what they mature. That's what the T's for. And they fight virus big time. And tumor cells. So because now that they lace tumor cells with viruses and a way of treating them, your automatic immune system is wiping out the tumor cells and all using chemo. It was more efficient. Because you know why? Once your body reads it and realizes it's there and I can fight it, it never forgets it. And it never forgets it because of these guys. These guys here will produce the antibody, the antigen-antibody response. So once they see it, they never forget it. And because they see it and they start it, you know, these come in and one comes in and finishes it. So, you know, these come in and finish it. These will be always on patrol looking. This guy finishes it. So one trains the other. But they're like non-forgiving cells. They're like ex-spouses, non-forgiving. Hate you till you die. Not really. That was out of time. The hate finally like dissipates 20 years later, 30 years later. Sometimes. Well, there's always a minimal dislike, but not a hatred dislike. Okay, so there's your lymphocyte. The second most lumens. Big viral fight. They'll fight bacteria too, but big viral fights. So usually when the body gets a virus, the body will always recognize it again. And that's how immunizations work. Immunizations don't kill you. They save you. Diseases kill you. So if you're against immunization, then you don't belong in the field you're going in. No, they do work. They do work. Well, you don't get sick from a flu shot. You get sick because you're getting sick.
No, yes, get the flu shot and then we'll get.
Well, you don't get the flu from it because it's not the actual flu they're giving you. It's a piece of its DNA or its protein they're using. So these guys recognize. So if you were on the verge of getting sick and I give you the flu shot, you do get sick because your immune system is overcompromised.
Yes.
That's why.
Right, because you're not supposed to get the flu
You're not
shot.
If you are sick, and sometimes you don't know you're getting sick, and they give it to you, now I'm sick. Because that's happened to me before too. This was the first year, knock on wood. I got the flu shot in September, and I didn't know what acute bronchitis. Because usually I have. And it's not because of the flu shot, it's because that was coming, and now that just got it there quicker. But the flu kills a lot of people. The estimated this year should be about 40,000 people die from the flu in the United States. Right now it's almost like 20,000 have died across the country. And you're worried about the stupid coronavirus. Because there's only 12 here, and they got total control over it.
I literally heard my clients, I take care of
Right,
someone,
I can
they're two
imagine.
nurses, and I heard them going back and forth. Do you believe that ship pulled up and they had 42 whatever on it, and 12 of them have the coronavirus, and how fast
And
it's
they
gonna
put you on
spread?"
quarantine, no, it's
I
going
was like-
nowhere. Put you in a bubble, staying in the bubble, and then eventually your body, look, viruses burn out eventually. Climate shifts, they're going to burn out and it will burn out. And China's going to take longer because they don't give a shit. The rich care and they're fine. It's all the poor people dying off. They don't care. And now they're thinking that the government released it.
It was a secret man-made that virus in the
It
lab.
is.
And Dr. Charles was.
It was a mutated virus that was created and they think.
That is meant.
So it didn't go from bat soup?
Well, yeah, but they put it in the
We
back.
don't see it
That's all my
anymore.
food.
Have you seen the pictures of
So,
the bat suit?
well, there's too many
Yeah,
people
is
there.
that like
You
his
could
apple
wipe out
cider
half
lady?
a billion, you're still got a billion and a half, so it's like.
I mean, I guess China has a history of famine, so people just eat anything.
So with that, let's go to the monocyte. Now the
So many
monocytes,
plants that they could have eaten instead of just going for the
they're very phagocytic cells, and they also fight big-time viruses and bacterial parasites and all this stuff. So they all fight the same stuff. And chronic infection. Chronic infection, you know, so they're a big immune response. Chronic infection is Epstein-Barr virus. There's a lot of battle between monocytes and Epstein-Barr. And in the early phases, they move on mono spots, and you can see these cells appear in the president, mononucleosis will go into, and they thought it was just infection of the monocytes. But now they realize it's not. The lymphocytes also involved a lot too, which is giving you a better handle on controlling this, Epstein-Barr virus. But we're going to go into that. But they activate lymphocytes to mount an immune response. They get it going. They fight first. Then the immune response means the other guys never forget. So they're the ambushes. So we let the virus come in, and then boom. So yeah, can you get the virus when you're not? Yes. But your body already has an immunity to it. You fight it off much faster. Usually 2-3 days and you should be back to yourself. And if you took an antiviral within the first 24 hours with the vaccine, you're going to knock it out of you, that the next day you're going to be back to normal. Your body will overcome it, unless you're immune suppressed. So the real elderly and the children, they can have an issue with it. That's why they need to be vaccinated. The healthy individual, no. But how's the flu kill you? It gets into the linings of the heart, the linings of the lung. Now the body can't get rid of it. It makes it tougher. That's how it kills you. Or gets into the kidneys and damages the glomerular line. So they can damage things. That's how it eventually kills a person. So that's why you see the counts that die. Now others have no immune system, so you die. You're on chemos, you're older, you're weak. Not a good mix. The boy in the bubble, John Travolta. Nobody else knows that, just a few. And he runs out of the bubble, it's worth it. I hope it was. You're laying in bed 6 months dying from now. You say to yourself, it was worth it. Okay, okay. So we hear a lot of this term too, interleukins. They use this a lot in treating, even in cancers. This term interleukin, okay? We're not going to go into all this detail, but you do see a lot. So it's just telling you how they form. So the other was erythropoiesis. This is leukopoiesis. Makes sense. They're on white blood cells. So it doesn't understand. Yes, hematopoietic hormone comes in, but stimulates the one I want. If I want erythrocytes, it's erythropoietic hormone, EPO. And if I want white blood cells, it's leukopoiesis. Okay, good enough. And we don't care about that. We don't care about this. It's the productions. I don't give a shit about production. Let's go into the imbalances. Well, you're not going to need that. It's not going to do you any good. You want to learn it, read it on your own.
Is this gonna be on the exam with lymphocytes and stuff?
Yes, ma'am. Oh. I know, yeah.
And how it's gonna be on our textbook, I think we're going
I don't know this time. It's going to hit the basics off the slides. All right?
Yeah.
I haven't written it. That's what they're going to start doing tomorrow, start working on the test. Well, we just look at next week, look at it, and then take your questions and write out questions. It's your life. Can't wait. I had to write 2 other tests already. I got 1, 2, and I get them, it's like, because next week AP1's testing, 10-7 is testing. So I get their test right. Their study guide right. So you go to the last study guide to get done. So we get the study guide done, this is material I'm going to ask you. So if you're comfortable with the stuff on that guide, you're fine. You know what each cell does, you're fine. We're going to go to the diseases that each one will fight and work with, okay? Like we did the anemias, correct? No, not yet. No. I'm thinking of last night, yes. Because they're like a heading, they're almost done. I did do all the anemias. I did IDA, pernicious. So I did do it with.
You did, yeah, because I did.
Yeah, not yesterday, but
Yeah.
Monday. Yeah. All right, because So the key I would ask you, what would be the main thing you're looking for in that CBC to know I have pernicious anemia versus IDA? Yes. It would be the cell size. Macrocytic versus microcytic. That's important because I did my own boards to get in to be an intern. In other words, 5 people drill you in their specialties of each of their field. And you sit there and you take an underclassman, in which it was like somebody first or second class, to use as a guinea pig, you're going to show them how you would examine the person. But one of the parts was the hematology part. And so he taught all this stuff. And he's the one you go to when you had troubles as an intern with the blood picture. And he drilled the shit out of me on that stuff. I remember that. He was throwing any picture of me in a case, video of the case, and then we worked it up and started over. And the key was the size of the cell. So we thought I was blowing it. I said, you know what's anemia is less. The cell's bigger and darker. So it's macrocytic. Has to be B12, pernicious anemia. And I hit it right out of the money. I never forget that. That's 40 freaking years ago. At this point in time, it's like January. So I was ready to go intern for the year. All right? I was a young one then, 25 years old. So there we go. So there's different, so many embryonic hormones, eat for erythrocytes, CS, are used clinically. So, in other words, if we have imbalances, they're going to use it. So, also used to increase protective immune in AIDS patients. So a lot of chemotherapy. Now, this stuff to get, it's like $5,000 for an injection, and most insurances don't cover it. So, if someone's suppressed, marrow suppression, because of the chemos and stuff, well, you're going to pay for these drugs out of pocket, and they're not cheap. You're looking at anywhere from $3,000 to $5,000 an injection. So you see these commercials, yeah, all right, the drugs do work, but they're not cheap, okay? So there you go. So just to give you that insight. So, all right. So when we have an overproduction, it's leukemia or infectious mononucleosis, right? And an abnormal leukopenia. So penia means less. Leukopenia. Osteopenia, decreased bone mass. Which leads to osteoporosis. Osteoporosis is the diagnosis. Osteopenia, you're just seeing on the film. So you would say the film was osteopenic, most likely due to blah, blah, blah. My differential would be this, and that. That's how you work up something. You just don't boom, throw the diagnosis out. Be one of those and you're going to get your head chopped off when you're in your clinical rotations. Because even the doctors are going to scream at you, okay? So here you go. So there's the 2 conditions. So we're going to look at these 3 conditions. That's important to me. Because that's what you're going to see. All right, so leukemias. Cancerous condition, like, what was the cancerous condition of the red blood cell? There's only one thing. You said I did it, right? Polycythemia vera. Does that ring a bell? Ding. Polycythemia vera. Crick goes up, hemoglobin through the roof. And the blood's like sludge. Well, same thing eventually happens here too. Blood gets thicker. Sludge. That's why the person's so tired, run down. So here we go. It was like I remember when he had one of these forms, and he would go they would go to a unit and they would actually clean his blood and we'd put it back in. And it wasn't from dialysis, it was from form of leukemia he had. And that's when I was teaching Henderson, and you were watching the change. And I told the kids, I said, you're watching him die right in front of our eyes. And he did. They were doing this like in the fall, by spring he died. Because nothing was working, so let's just filter the blood out as much as we can to wipe out the white blood cells and the body. And that's what they were doing. And he passed. So there you go. So you have, you know, myeloid leukemia involves the myeloblasts, lymphocytic, the lymphocyte. So there's two forms, and then you go acute and chronic. The acutes are more common in the child, the chronic in the adult, but the chronic can lead to the acute forms in the adult, and when it does, the adult dies. That's what's dangerous. Okay, that's when it becomes dangerous. So there's your two forms. So acute advances quickly, you know, because leukemia is derived right out of stem cells. Primarily affects children. So acute myelocytic leukemia, acute lymphocytic leukemia. Now, a lot of people get chronic myelocytic leukemia as an adult. And if they can keep it there, they're fine. If it reverses into the acute form, they die. And they die within a year of dying. They go quick. And I had a couple of my nose that had it. It's weird because it was a picture of football, one of the Paradise School. The guys that were all from Rhode Island were on the same team. And there's one picture, there's three of us in the picture. And the other two are dead now, so it's weird to look at the picture. One died while we were in school. And it's the natural causes, I believe. And the other one died of leukemia. There was three, and the other guy died of renal cell carcinoma, so there's four of us. So renal cell carcinoma, and so they're all gone. And the other one who died, he died in 1979. He died while I was an intern. If all of them did, he died. He had the flu, he was working double shifts, covering other shifts, other interns, and that night, I don't know what they did, they couldn't remember that. They shipped his body back here, because he was a year ahead of me, so it was tough. But I knew one of them from high school, from URI, went out there, he went a year ahead of me, but I remember he was my roommate for my first year, and then passed. So he was 26. Like a waste. He was 6 weeks away from completing his internship. He died. So that's like a waste of a life. And they said it was natural causes. I was a young person, natural causes. But whatever. But you can see, so here's your two types. So all you would do is put acute or chronic in front of this. So it'd be, you know, AML, you know, or CLL. So that's how they make the leukemias. And this one's really bad, because it's coming from there. The myelogenic forms are bad, coming right out of the marrow. And when it's acute, it's really bad, okay? So, leukemias without treatment, they're all fatal, okay? So this one, they're all fatal. And it's a cancerous, so it's, pretty much it's cancer of the bone marrow. It's as simple as that. Leukemia is cancer of the bone marrow producing the white blood cell. So is the other one. Polycythemia, cancer of the bone marrow of the red cell. So eventually these diseases are going to they can take. Now they do a lot of what? Bone marrow transplant. And in some cases they work. You know, death is usually from internal hemorrhaging or overwhelming infections. Eventually it's going to happen. Because you have no immune system. And in some cases, you can get what they call a leukemoid reaction. Meaning your white blood count goes to 50,000. And they may think you have leukemia, and they say, I treat you for leukemia. And it's not. It's the body fighting a real bad infection, and they kill you. And then I've known a couple of cases where that's happened. They killed the person because they treated something. It was the body. No, why are you wiping out these white blood cells? We need them. The body's fighting a real severe reaction, and you get a leukemoid reaction, and it wasn't cancerous. If they treat it like it's a form of leukemia, they will kill you. Because they'll suppress the marrow. The infection's there. The infection takes over, and it wipes you right out. So this there's a lot that goes on in people in us. It's not as simple as A, B, and C to figure out what's wrong with people, okay? So like I told you, treatments will be radiation, anti-leukemia, and stem cell. The biggest one now, they use this. Hopefully it works. If it works, then you are, most children that I've known with it are now in their 30s. They're cured. They're cured. And I remember them when they were 3, 4 years old, going for the therapies every week and all this stuff. And the child usually had a good outcome. You know, it's like that hospital there, the one that deals with children. Their outcome is tremendous today with cancer compared to what it was when I was a kid. Yes, St. Jude's. And that's one I donate to all the time because they are unbelievable. You pay for nothing. Pay for nothing. Whatever the health coverage pays or don't pay, they don't care. You pay for nothing. Plus they pay for the parents and the state. That's big. Dana Farm is a division of that. They have one division.
It's from my aunt doing so.
Yeah.
It's no harm.
Right. So those hospitals are big with this stuff and controlling it. A lot of research people.
Ronald McDonald House as well.
Yes. And the Cardis have done a lot around the stuff. The furniture company. They donated all the furniture. So I went to high school with one of them. Ron. Played football, so he was the guy, I was the guy, played side by side, 71. And that was when Van Egan played, and Van Egan went on, he became a big time running back for the Oakland Raiders.
Yeah.
He made all pro and everything, like Van Egan. Oh yeah, he was good. He set all records. He was this little skinny kid in high school, he blew on and he fell over. He got bigger in college and areas, he was in pro football, and he comes like, what it was Marcus Allen got injured. He replaced him. And he was there running, and then he retired after 2 years with the Patriots. So there are people that come out of here. Rocco Baldelli. Yeah, Rocco Baldelli came out of Hendricken.
Bless you again.
Will Blackman came out of Hendricken, played for Green Bay, all these big pros. I coached him when he was in Hendricken. When I was teaching him as a coach. We lost to East Providence for the championship.
Yes. Oh my gosh.
But this kid was so good, it'd be like when you needed the first down, Will left or Will right. This kid was just so fucking fast. He already looked like a pro football player playing with high school kids. And I saw him run for the first time. The cuts this kid could make, he would make moves that you'd be both closed in on him, and almost he'd be gone. That's how fast he was. People would have dislocated their shoulders as they were coming in to tackle. Because they'd be all tangled up, and once he'd be gone. It was just a natural athlete. This is common, kissing disease, right? Cheerleader has it, the whole football team gets it. Does it kiss everybody on the football team? Probably not. It could have happened, but no. And no, I didn't get this as a kid. I wasn't the lucky one on the cheerleader. But so the reason is, you don't share the water bottle. Because you get nothing out of the squirt, so you take it off and you drink from it. And that's why those all freaking get sick when they play these sports. Because you all drink from the same water bottle on the damn thing. Now it's more sanitary than it was in my day. You didn't give a shit. You know, so you did. But the point is, you picked it up because it spreads through the saliva. You know, and it's Epstein, everybody has Epstein-Barr. It's what your title is. If you have no symptomatology, somehow you got this, and I could have had it. I remember being sick as a dog with a back sore throat, everything swollen, but you run the street, so I was like a junior, so in high school, and we still played. And one day I was just like, couldn't even swallow, it hurt so much. And it went away after 3 weeks. How was that? Because now I got the chronic fatigue with this freaking Epstein-Barr, we'll go up to 1800 when they tighten. Because one time I went to the primary, a couple years ago, Frank, it's got the shit. I feel like crap. Would you run some freaking tests, see what's going on? I don't care what the hell it is, I want to know what's going on. It came back this. Everything else was normal. It wasn't low T, it was low T. T does go low as you get older. What's T? Testosterone. And I don't believe in supplementing that. When you supplement those, that's cancer. So they look good and have more energy, yeah, and then they'll get cancer like 2 years from now. So I look good when they lay me out, okay? So there's Epstein-Barr. So this is very common in people. And they always thought it was the monocyte, but really it involves the lymphocyte. So yeah, you run them on the spot, but also run a CBC diff and look for that. And tell them, focus on the lymphocyte. Because this is what I think I have. And that's what they do. Because that's going to raise right away. And they'll be 30% atypical looking. They don't look normal. Because they're trying to get there so quick. So that's, originally thought it was, that's why they called it mononucleosis. But it's been around forever. And that was its name, kissing disease. Because that's how you spread it. So which one do you kiss? It's true. Get sick. And don't kind of get tired, you kind of feel like, take this out, most of you feel this way all the time anyways. You're going to start learning diseases when you're in your courses, you're going to swear you have them. I know I got this, because I have every one of these. And you do, you start thinking you have half this shit that you're going to start reading and go, oh my God. And the other bad thing is, when you go for a test, you know what they're looking for. And it's like, shit, if this come back positive, I might as well go buy that Ferrari because I ain't gonna have to pay one payment on it because I'll be going. And I'm right ready to go, I'll just smash up with it near the end and go off a bridge or something, we go in one shot. You don't have to worry about suffering. The more you know, yes, it's good because you understand, the worse it is. Because you think the worse. Yeah, I had an H off an MRI in your head. Oh, I know there's a tumor in there. Oh, there's something in there. And even with you guys today, when I first would do x-rays, I'd read it, and you'd be saying, I know there's a big tumor right up here and I can't see it because I didn't go high enough for the reason. And there's nothing. So half the thing is, you're going to look at things, looking for diseases, and they really aren't. They're normal. And it takes time to get the clinical skill to realize it's normal. And that's what you develop. That's why it's called practice. Because you practice every day. When you become a know-it-all, it's time to get out. Because you learn something new every day. Something will be a little different. And you learn new from other nurses, other doctors, you learn from them. So don't be a know-it-all. That's when you hurt people. And usually 4 to 6 weeks, unless it becomes chronic. So leukemia is bad, mono bad, that's what we're learning, it's not good. And now we finally get to platelets. There's not much that suppresses the white blood. The only that's going to suppress it would be marrow suppression. So you're not really going to suppress the white count. Just like the red count does suppress easily. The white count doesn't. So one thing you might ask me though before we go forward, how do I know it is a virus? I look at my count, and my count is sitting like 9,800. Person feels like shit. Feverish maybe. And the neutrals, but they're all normal. But instead of having only like 40% of my limbs, I have 60%. That's how you know it's fine. They went up. Total count doesn't have to increase. It might even decrease a bit. But the limbs, the guys that usually look for viruses, are elevated beyond what they should be in high ratio. Now you know you are, you have the virus. Bacteria is easy, that you know. But the other one, that's how you know I'm dealing with a virus. Okay, now you figure out what. So platelets, they're fragments. They come from this guy, a megakaryocyte, and then they fragment off it. Problem with platelets, they don't live long. That's the biggest thing they're always looking for, is platelets when they're doing blood transfusions. When they come along for donating blood. The biggest thing, because platelets, let's say over here 10, they don't live 10 days. They live maybe 72, 84 hours and they're gone. Especially when they've been transfused out. So So they need them. This is important for what? Blood clot. That's the biggest thing they're for, blood clot. So when you take aspirin, we're going to go into that. When you take aspirin, it doesn't go in and stop a clotting process. It just makes it less sticky. So the blood flows easy. So that's kind of how it works. So when you form, so the foam platelet formation is regulated by testosterone per week. It's a hormone that's designed to take from the myeloid tissue and create these megakaryocytes. Just like you created white blood cells and you create red blood cells, now we're going to create megakaryocytes. So that term that's on your study guide, megakaryocyte, that's what it becomes. And then it fragments into a platelet. And normally the normal count, depending on labs, every lab you use will have their own range. So when you do lab work on people, no matter what you've tested, the range is always there. And then they'll give, might mean this, and they give all these different diffs with it. And then, if you're in normal range, it doesn't say anything. You look at your number, if you're low, there'll be a low next to it. If you're high, there's an HI next to it. So if you freaking miss it, what the hell? Didn't you read? I've seen people miss. One of my colleagues got two blown urinary tract. Oh yeah, I looked over here, and while he's talking on the phone, I'm looking at the results. Oh, get on hold for a minute. You got freaking urinary tract. Can't you see? What the hell? You don't just have white blood cells in the urine and leucorrhea in the urine. That's not supposed to be there. They break it down. And then high red blood count in the urine. I said, then look at this. Look at the diff. My God, you got white blood cells going to the roof. There's nothing wrong. Change the antibiotic. My God. Oh. Too busy doing other things, not paying attention. That happens a lot, people. Pay attention. The only thing that matters when you walk in the room is the patient in front of you, not the boyfriend you're fighting with, not this, not the car you're going to buy, or the trip you're going on. Yeah, it's tough because you're leaving that afternoon to go, but while you're there, the patient comes. Or take the damn day off. That's how mistakes happen. And some of you already work with it and see it. Okay? So there's your normal range. We'll go with this. For white blood, we can go 5 to 10. Keep it at that. When I told you. For red blood, 4 to 6. Keep it easy. 4 to 6 million. Keep it round numbers so it's easy. Know the diff though. That makes up most of it. 50 to 70 would be neutrophil. The next guy would be the monocyte. Okay, so know that. That you should know off your mind. So get it there. You're going to need it anyways by fall. Things go the way it's supposed to. Let's hope it does. So I don't see you just moving around the swimming. Well, it's the only place in the world that has nursing. And it shows you how we're finally, so we go from that, and we break apart. We don't give a shit how it does it, we skip over it. All right, so what happens when hemostasis? Hemostasis is a reaction to stop bleeding. These are now, there's 3 stages. Just know it. Vascular spasm, platelet plug, coagulate the blood. So yeah, you want to spasm off the end so the blood supply slowing down, going there. Then we want to form a platelet plug and then coagulate the blood. So we stop the bleed. Okay? And skip. Okay? So just know those 3 facts. That's it. I'm not going to go into blood clot. This is shit on its own. You don't realize this stuff is so heavy. 2 pathways. Just know there's 2 pathways you stop the bleed. Intrinsic versus extrinsic. Got it? Intrinsic. When you're looking at the study guides, it has like factor 8, 9. No. We're not going to worry about it. You want to worry about it? Then go take hematology. Then you'll worry about it. Alright? For our level, we don't need to worry about it. To go into all the detail on that is insanity. because that is a way to remember. This was 2008, I found out. Well, how about Happy New Year 8? No. You follow what I'm saying? So mainly, there's two pathways we're going to run, intrinsic versus extrinsic. Intrinsic is the bloodstream doing it itself. Extrinsic means we extract a product called tissue factor, and that's going to help with the bleeding to stop. So intrinsic means happening within the pathway of itself, within the blood vessel. Everything we need is there, okay? Extrinsic means we're taking it from we're taking it from the tissue factor. Simple as that, tissue factor. You can't remember coming from the tissue factor, come on. The final thing is we want to form prothrombin, the prothrombin, we want to form a clot, and it stops. Now, when you take certain meds, that are anti-clotting meds, they actually interfere with one of these pathways. That's how they work. They come in and block this step. If I block this step, I can't form a clot, I shouldn't form it in blue eye, I shouldn't drop dead. So they have me on the warfarin, or whatever. Coumadin. So they put you on that. Aspirin doesn't do that. Aspirin just makes everything flowing around less sticky. So they don't get stuck together so easy when the blood stops. If you pool the blood. Because when blood pools are like suoglutamate, and there you go. So you kind of cut that down. Alright? So there's what you need to know. So there's the thing, we don't really care. So we're going to go over this, common pathways. If you really want to learn it, then I'll do it with you. But I can't see the sense. Vince and I talked about this, we're not going to go into it, okay? So in here it'll give you where everything comes from. If you're really into it, there it is. Read the damn chart. That's for you. If we blow over it, that means what? Thank you. So let's go into stuff that's interesting. The disorders, the breathing disorders. So just blow really fast. So in other words, everything that I've gone, we just make courses. You want to read it after, then read it after when the course is over. Because eventually we will go into the details. We don't have time. We don't need another week of this. Okay? I'm sick of this. This freaking system is like the never-ending story that don't end. You know? So, thromboembolic disorders results in undesirable clot formation. No kidding. Bleeding disorder. You bleed too much. So, you know, no kidding. Bleeding disorder. Two major disorders. Okay, we're happy. Thrombi and emboli. This kind of important because they kill people. Right? DVTs. P's. Well, that's this stuff. So a thrombus is a clot that develops and persists in an unbroken blood vessel. So you have these big varicosities, damage. So they, I know everybody across the leg.
Susie
That's
said that,
supposed to. Yeah, it's supposed to put your leg up like this.
Just across.
Everybody should sit with their legs up.
Supposed to cross ankles, not knees.
Embolus, you know, now it breaks and starts floating around. Embolism, so it's just telling you something you already know. And where does it usually go? Lung or cerebral. If it goes in the brain, that's a stroke. That's where it comes from. Risk factors. Is that something here it doesn't make sense to you? The risk factors? No. So you know this already. Hardening the outer cross. Instead of being this big, it's this big. So it's easy for things to get stuck in there and start building what? A thrombus. And eventually a piece decides to let go, and now you get your emboli. Flowing around, goodbye. Simple as that. Inflammation starts the process for this. Slowly flowing blood or stasis. You don't want to stagnate blood. It makes clots. It likes to get sticky. It's sticky to get with blood. Mammalian blood, it tastes minerally and it's sticky. It is, it's naturally sticky. So, common sense. So to ask you that, you know, what's the risk factor? I mean, you should know. Perfect in shape person, perfect blood pressure, but they're not a risk factor. Anticoagulant, aspirin, antiprostatic, so it stops the prostaglandin process. Prostaglandin mean inflammation. You don't want these things flowing around. Cuts it down, cuts the stickiness. Heparin, used clinically for pre and post-operative cardiac care as well to prevent venous thrombosis. And warfarin. Oral anticoagulants reduce stroke in patients, and AFib goes up, interferes with the action of vitamin, because vitamin K is needed for clot formation. But that fact is to change from the factors that you were looking at. Vitamin K is important for the factors that go from 8, 9, you need it. That's why vitamin K is important for blood formation, clot formation, clot formation. So I would know that. You're going into nursing, you kind of should know that. You know, this is what they give. That's, you know, in rat poison.
What's a rabbit? It is?
They hemorrhage to death. They bleed out their gut and hemorrhage to death. If I give you this, you don't need it, I wouldn't hemorrhage you to death. So don't drink that coffee. So, yeah, so lowers, and aspirin does work to lower. Really, anybody over 50 should be on 81 milligrams a day. Over 35 if it's cardiac risk in the family. You don't bleed to death. Then they say over 75 you should stop taking it. Because then you get on issues. They say a lot of things. So that's the stuff I find interesting, not the damn pathway. Just remember they're going to go in and block those pathways. These. This one, no, but these two do. They actually go in and stop the pathway from happening. And they'll tell you, it's either going to work on the intrinsic or intrinsic pathway. You know, the reps will tell you that when they tell you about the drug. Thrombocytopenia, a deficient number of circulating platelets. Not really that uncommon. You find it on certain people. Suppression of the red bone marrow, malignancy, radiation, or drugs. How about a drug addict? Those don't exist. Drug addicts. Doesn't exist. There's all kinds. So when you see this stuff, probably you're working around the hospital ER, you'll see it. So there you go. And you're going to see this if you're working in a cancer center. So they give transfusions of platelets. There's petechia, these little red marks all over the skin.
That looks like plasma pin.
Yeah, but that's not.
I know what it looks like.
It looks like it. Yeah, foot and mouth disease. Bleeding disorders, impaired liver function, because liver is needed. Look, synthesize clotting factors, including vitamin D, K deficiency, hepatitis, or cirrhosis. You need, so the liver has an important role, which is needed to absorb fat and vitamin K. The fat's bad for you. K is a fat soluble. We make this in our large intestine. E. coli is. It's a bacteria that we use. But you ingest E. coli, you'll get sick as hell, but in your colon, that's fine. You wish you were cool. It helps synthesize vitamin K for our bodies. So there's that symbiotic relationship of good bacteria, bad bacteria, and all that stuff that lives on us. Bacteria lines your skin. Hemophilia. You'll find these. A, most common, 70%, well, due to C factor 8 deficiency. It's telling you what's missing. So go back and look at the pathway and you'll see what's going to happen. Let's look at the pathways. That's not there, I don't go to this step. It's not there, I don't go to that step. Simple as that. I want to bleed. Bottom line, with hemophilia, you bleed, especially into the joints. And what will happen is someone who don't take care of themselves, they'll bleed so bad into their joints that by the time they're 25, they'll have the joints as if they're 95. Because bleeding into the joint destroys the joint and inflames it. Doesn't help. So they give you clotting factors to help. Especially now, genetically engineered factors, they didn't have this years ago. But they're back. Any of the forms you can fit. So what's hemophilia? A bleeding disorder, right. I don't clot. Now you know what it is. Okay? I'm going to ask you A, B, C, but what's hemophilia? Bleeding disorder, I don't clot. Done. Go on. Genetic, too. It's genetic, not acquired. I don't care about that. Blood transfusions. So blood transfusions, why? We don't have to worry about that. Right? We just take blood from anybody. Why don't I put this before blood typing? I mean, it's so stupid. Huh? Well, to do this, you're going to do blood typing, and blood typing is after this, so it's like stupid. So forget it. Okay? Forget it. Whole blood transfusion. Whole blood means you're giving everything. Everything is going. The packed cells, plasma, everything. So here, plasma are removed. So depending on what you're giving, so whole, when you're taking everything, they're taking cells, they're taking plasma, and they're taking the platelets. Depending on what they want, they can reverse it back into your body and just take what they want. If you just need the volume, we take the blood, the packed cells, and we put the other stuff back in because we don't need it. So about a little over a month is the life of blood. So this is what's important. We get into the blood groups. So antigen, anything received is foreign that can be generated by immune system. So you hear of the antigen-antibody reaction. So type A blood has type A antigen. So what would be the antibody it has? Antibody B. I can accept A, I can't accept B. So if I'm type B blood, I'd have the B antigen. And then again, it's A, so I have antibody for A. AB has antigen A, antigen B, no antibody. O, forget it, I can't take nothing. O can go to anybody because they carry nothing. So there's 4 types. A, B, AB, and O. AB is known as the universal acceptor. O is known as the universal donor. Makes sense? You did that in lab yesterday, right? Yeah. Somebody did this in lab. So when you do lab Friday, you're going to do blood typing on the computer. And you get a quiz. So everything we kind of talked about, you're going to do on Friday in lab on the computers. And I told them the hearts are pretty crappy. We're using all the plastic models.
Oh, thank Jesus, because I
The
literally
only,
just said that.
the only live tissue we'll use is the pluck. Because the pluck shows you the ligamentum arteriosum, the pulmonary artery vein, and primary bronchi. So the pluck will be used just to see those specific things that you don't see. Yes.
I had a nightmare trying to take a lab exam on those hearts.
I
Well,
used to
the one we
last
do
night
is
really
because
disappointed
that-
with that.
You learned from it?
So beat up.
Well,
They are really beat up.
Yeah. I have
Yeah.
pictures
Thank
lined
you
up
so
and
much,
everything,
guys. I
little
literally
dots.
just-
yeah, Betsy and I talked about so that they don't get the plastic.
I went to
So there'll be a
work.
whole,
Fine.
a whole plastic.
Getting punished for being a
half
good
plastic,
student.
Right.
A plug, and then a few models of the vascular system.
Honestly, it's gonna be
Make
looking
sure you know where the azygos vein is. You know where it is?
There's one model that's better than another.
Yes, the one on the torso man that has the good azygos, that will be pinned. So if you miss it, I don't feel bad for you.
Which one? There's two torsos.
The one has a better, the one that sticks out like a big blue line that you can't miss it. Good, good, good,
So
good.
I'm not gonna have you like breathe down my neck, because there's nothing I'm gonna do. How am I gonna, I know, that's what I'm saying, how am I gonna get this exam out without,
Oh, you'll be fine. It's easy.
I'm busting you, man.
The actual questions that will be phys questions are right off physio class.
I can't answer, it's not gonna be.
All right, remember the questions you did on physio X? Those they'll come right from there.
Okay.
All right? And then there'll be easy ones like, what did you use this for? And you're gonna speak there. Oh, I wonder what I did with this thing. So,
Is it two tables?
that's the practice.
Two tables of questions, one table, how are you, because that's what I'm figuring. Like, we're gonna have more questions.
It's
than
gonna be
actual
like,
questions.
maybe total 50 altogether.
Okay.
I can't make that many.
That's like not bad at all.
No.
All right.
It's only one system.
All right, I'm all right. I'm feeling better about my. I literally
It's
had a
only
hard
one
time
system,
with hearts
people.
last night.
Yeah.
It's not just one system, the practical, which is rare. Usually it's 5 systems. All right, so I made you happy, good. So let's look at this graph. Okay. So human blood groups, you know, we have antigens of A, B, and O, and our H blood groups caused by. So what happens when I give you the wrong blood? Well, you die because of the glutenase, okay? So here's the thing right here. So type A has a gluten so antigen A. Type B has antigen B. AB has A and B. O has neither. It's O because it has nothing. Why do they call it? I don't know. They called it C. But they called it O. It has nothing. That's why it's a universal donor. We're going to get to that. Relax. Okay. So blood type, you know, you have anti-A or anti-B antibodies. So it glutenates. So if you're A and I give you B, your blood's going to gel right up. And that happened many years ago, and they didn't know this. And then we're going to go to another thing that they call, it's showing you here. So this is another, so did you pick RH. And this was from the rhesus monkey. They picked it up. That's why it's RH. And 52 named, and if all is the protein, and you either have it or you don't. And if you do, you're positive. If you don't, you're negative. Why is this important? The biggest role where this is important is having a baby. Like a song. Having my baby. So there you go. So, all right. So let's make a little story here. Mom is RH negative. Dad's RH positive. Little Billy inside the womb is RH positive. What is going to happen? Negative.
Negative and dad and baby are positive.
Yes. Because somebody had to be positive to give it positive. So, well, with the first baby, mom's going to build antibodies against it. But nothing happens. The baby is going wrong. Mom gets pregnant again. She gets pregnant again. Love. Every 9 months have a kid. All right, so she gets pregnant again. Well, they had no TVs then. So she gets pregnant again. Same thing. She's negative, baby's positive. What happens? Baby's going to die of hemolytic disease known as erythroblastosis fetalis.
So first baby, okay.
Second
She's already
baby,
built
right.
up the.
So what would I do to prevent it? If she's going to get pregnant, I give her a product called Rogaine. Rogaine will go in and she can't, mom's body can't desensitize to see the positive RH factor and the baby will be born.
give it while she's pregnant?
No, you give it to her before.
Okay.
So that, you follow what I'm saying? So the first baby will be fine. But now she's built up antibodies. So the next time another baby's in the development, their body realizes, this isn't right. It attacks the blood cell, and the blood cells just blow up. And the condition is known as erythroblasts, because they blow up inside the fetus. Erythroblastosis fatalis.
That sounds
And you know, as an RH mom with an RH positive fetus on the second one. On the second one. Okay? Whew. Talk about transfusion next. Almost done. Transfusions. So we're getting into transfusion stuff.